Hello, everyone. Thank you so much for joining us today. My name is Dr. Kwame Akoto. I am an adult and family medicine physician at Kaiser Permanente at the South Baltimore Medical Center. And I am proud to be joined today by my incredible colleagues, Dr. Natalia Berry and Dr. Amaya Kulkarni, both cardiologists at Kaiser Permanente. As a proud supporter of the American Heart Association Healthy for Good program, we are excited to talk to you today about 4 critical numbers that impact your risk for heart disease. We look forward to your questions, so if you're watching live, please post them in the comments as well. Let's go ahead and dive on in. So Dr. Kulkarni, I'm going to start with you. If you could tell us, what are the 4 numbers you need to know for your heart health?
Thanks, Dr. Akoto. These are 4 numbers that are super important in understanding what your risk of heart disease are. And those 4 numbers are cholesterol, blood pressure, blood sugar, and the BMI. So it tells you a little bit about your weight and what your cholesterol, blood pressure, and blood sugar are doing.
Thank you very much. Dr. Berry, can you tell us why these are important? What effect do these numbers have when it comes to our heart health?
Yeah, I mean, I think this is such an important question because obviously we can tell our patients that numbers are important, but getting them to buy into why I think is just critical. So, starting with blood pressure, it's a number that can be easily measured, and essentially an elevation in blood pressure can directly damage cells and blood vessels. It can cause blood vessels to get stiffer and narrower. And the direct damage can actually kind of interplay with some of these other factors like cholesterol to cause deposition of cholesterol in arteries. So leading into that, or that was a natural lead into, cholesterol. So in particular, the body needs cholesterol. So every cell in the body has cholesterol in its actual membrane, which is kind of the outer lining of the cell. So cholesterol is essential, but the key is not to have too much cholesterol. So the right amount is really the key here. So LDL in particular is the bad cholesterol. And that's directly linked to buildup of plaque in arteries. And so plaque in arteries, if there's enough buildup, will cause narrowing and can lead to things like heart attacks and strokes, as well as other problems. So that's the main kind of takeaway point for the LDL. If we look at BMI or body mass index or being overweight, it's really a critical thing, I think. Some of the studies show that just being obese or overweight can take 3 years off your life. Severe obesity takes up to 10 years off your life, or it's equivalent to like a lifetime of smoking. And that's really critical because essentially almost all of that is driven by heart disease and heart problems that arise from obesity. Obesity drives directly elevations in blood pressure. So all these other factors we're talking about, LDL changes that are unfavorable, as well as blood sugar elevations. And so, obesity and kind of maintaining that, or BMI targeting, is really important. The 4th number that Dr. Kulkarni mentioned, blood sugar. Sugar itself, obviously everybody needs some blood sugar because it's how we sort of function and metabolize and how we have energy. But essentially too much of it, again, similar to the LDL story, has direct effects that are toxic to blood vessels and direct toxicity of the heart. And generally speaking, if you have elevated blood sugar, you have approximately 30 to 50% higher risk of heart disease. So there's a direct link there as well. So all of these things are really both important on their own, but I think there's an important interplay too that I try to impress upon my patients when I speak to them.
Thank you for tying that all together. That sounds very interesting to know those numbers and how they all tie into our health. Dr. Kulkarni, let's talk a little bit more about the practical side. So now that we know what these numbers are and what their effects can be, what steps can we take to lower our cholesterol or our weight or blood pressure or blood sugar?
Yeah, that's the real question, right? Once we know the numbers, once we know what's going on, what can we do to translate changing those numbers to reducing risk? I think that's the question that everyone's asking. And so taking one at a time, just like Dr. Berry did, starting with the blood pressure. If your blood pressure is high, the single best intervention you can do to reduce your blood pressure is to reduce the amount of salt you take in your diet. And it's interesting, over the years, what has happened is that a lot of the packaged foods and now even a lot of fresh foods have salt in them that you may not even recognize. The goal is if you are a average American adult, you should have about 2,000 milligrams or 2 grams of salt in your diet per day. And I would say most people in America are getting more than 3,000 milligrams just by eating the regular foods of the day. And so taking the first step of just paying attention to what you eat, doing a food journal, identifying the amount of salt on average in your diet, and then really just cutting out sort of the big salt items, that's a great place to start to try to reduce your blood pressure. I give the example, a slice of bread has 150 to 240 milligrams of sodium in it. So just paying attention to how much sodium is in your bread could save you a substantial amount of your salt bank, if you will. So that's blood pressure. The next one is cholesterol. And Dr. Berry was mentioning that there's good cholesterol and there's bad cholesterol. Focusing on the LDL, which is that bad cholesterol, the 2 best ways to reduce bad cholesterol, one is again in the diet. So if you're eating a diet high in saturated fats, if you're eating that things like bacon or terrestrial meats that are high fat, you're going to get a lot more fat in your diet, and that can increase your cholesterol. And then the second thing is exercise. People maybe sometimes don't make the connection between exercise and cholesterol, but we do know that if you do a good amount of aerobic exercise a week, so I say 30 minutes 5 times a week or 40 minutes 3 to 4 times a week, that you're doing the work of increasing that good cholesterol and potentially lowering that bad cholesterol. The third thing is blood sugar. I would say the same rules apply. So diet and exercise. If you focus on the amount of carbohydrates in your diet, by reducing those carbohydrates, you can potentially reduce the effect on blood sugar, and exercise has a great impact on blood sugar as well. And finally, BMI, as Dr. Berry said, that's the string that ties everything together. If you're paying attention to your salt and your fat content and reducing the amount of carbohydrates in your diet and doing the good amount of exercise, that BMI will start to come down now. I do want to say one thing, and I know, Dr. Berry, if you have any thoughts, or actually Dr. Okoto, you may have thoughts about this as well. There is this new wave of medications that help people who are having difficulty losing weight, using traditional means to use medications like Ozempic to lose weight. And I think that can be a meaningful part of a heart healthy program, but like everything, it's a medication with potential side effects, and we want to make sure we're sort of thinking about it in the context of the whole condition. I don't know if either of you have thoughts on those new medications for weight loss.
Yeah, I think that's a great point, and I think they're getting a lot of media attention. So it's good. It's really great that you brought that up. I would say that I think that it's sort of one part of the pyramid, but the base of the pyramid should really be that totally holistic approach to lifestyle and exercise that really starts when people are young, and really needs to kind of, I think as we get older and we have our own children and grandchildren, it's something that like we can kind of give to them, as kind of a mindset or share with them. And I think Ozempic is really good for people who have tried all of that and are truly committed to a good sort of lifestyle and are careful about their food intake, especially the carbohydrates and sugars, like you mentioned, and still have trouble, because I think there is a genetic predisposition to obesity that can't be overcome by lifestyle and attention to diet. But I think it's not kind of a pill for everybody. And I do think you're absolutely right, Amaya, that there are side effects that we don't yet know because we haven't had masses of people on these drugs for a long time. So it's good to be cautious, although I will say that the data out there for these medications have really been tremendous. They're truly a game changer in the system as well. So just a little bit of caution, but certainly a lot of optimism with those medications, and just, they're probably not for everybody.
Yeah, I think that's a really great point that you both bring up. We definitely get a lot of questions about this. There's a lot of excitement in primary care when we see our patients in terms of these medications. And just as you both mentioned, I think it is just one piece of the puzzle. I do still emphasize, even for patients that are on these medications, that they're really trying to approach all these other interventions from a lifestyle perspective. Another thing, if you actually look at some of the research for some of these drugs, around about 12 months or so, which is kind of consistent with a lot of other drugs we've used for weight management, it starts to plateau in terms of the effects that you have there. So we don't want people to let up off the gas in terms of their lifestyle interventions just because they do have this additional piece. The same way we would tell a diabetic patient on insulin, keep trying to eat well, exercise, sleep well, all the good, lifestyle interventions. We still want to maintain that even if you do end up on these drugs. But that is a discussion definitely to have with your physician, whether it's something that's you're eligible for, whether it's an appropriate drug for you, the side effect profiles, all of those things. It's not as simple as it sounds in the media. So I do make sure to really kind of sit down with patients and think about their goals when we talk about drugs like that. We do have some questions in the chat as well here. So the first question, and this can be open to either of you, it says, if you take your blood pressure regularly and it takes a couple of times to get it under 120/80, is that worrisome?
Yeah, I'm happy to take that one. I would say that blood pressure, first of all, is quite variable, and it's normal to have it rise or be elevated after some exertion. So for instance, like if you climb a flight of stairs, your blood pressure could go up 20 points. And so the important thing is looking at the average. And so what I usually tell my patients is if their first value is elevated, especially if there could be a bit of an anxiety loop about this. You take your blood pressure, you get anxious about it, and it kind of drives things. So certainly stress can elevate it as well. So if it normalizes and people can relax to the point where they get a good number and their average is generally in the good range, then that's okay. I think it's very common for the first value to be slightly elevated. So I usually don't take too much stock in that. And I have some patients who I honestly can't trust their office blood pressure because they're so nervous when they come to the office. So I trust more the home blood pressures than I do the office blood pressures as well.
Thank you. We have another question here. Can you explain how the number of 200 or less is derived again for cholesterol?
I can take that one. So the 200 total cholesterol number for what we call normal, it comes from very, very old studies that sort of correlated total cholesterol with the risk of heart disease, or actually I think it was risk of death long term. I will say that the testing has gotten much better. So we always knew there was good cholesterol and bad cholesterol, but because the only thing we could measure was the total cholesterol when we worked backwards to the LDL. We used to pay a lot of attention to the total cholesterol. I would say in modern, and at least in my practice nowadays, for the most part, I tend to ignore the total cholesterol unless it's very, very high. And I spend a lot of time paying attention to the LDL and the HDL because I think that those component cholesterols are much more important in terms of predicting risk. I don't know, Dr. Berry, if you have a different perspective, but that I tend to put much less weight in the total cholesterol.
No, absolutely. I'm glad you got the harder audience question, by the way. So I'm glad you took that one. No, I also think as we move towards more like precision medicine and kind of really being able to test in a way that we can treat patients on an individual level, I think that all of the understanding that we have about some of the subtypes of LDL will become more and more important. So the LDL, it has more than 9 subtypes, and we've learned that 1 or 2 of them are particularly important in terms of their risk. So I think that we'll be able to even subcategorize risk within, people with elevated LDLs. And I think that'll just help with, the conversation and the kind of the importance of both modulating lifestyle and then if people need it, medications.
All right, thank you. And I'll add also from a primary care perspective, we get questions about lifestyle interventions all the time, every day, which is, our bread and butter. And one of the things I really try to emphasize with patients is from a diet standpoint, one of the things I think makes it simpler is if you look at your meals the same way you look at everything else, have a plan. If you sort of kind of eat on the fly throughout the week on the go, makes it a little bit harder to be able to do the sort of things that you guys have discussed to keep your numbers where they need to be. So have a plan, and I do this even myself. So on the weekend, I sit down and we make a plan as far as what we're going to eat from Monday through Friday, so that we have a plan as far as what we're going to go buy and cook and things like that. So you can structure it in a way that works for you and your family or your job to make sure that you're getting all these things in there. But if you sit down and actually think about it deliberately, I think it makes it easier to make these interventions. If you try to do it on the go, you're hungry, you're tired, you're stressed, you're doing all these things during the day. So it makes it harder to do that. In terms of activity, I also do encourage people to move in a way that you enjoy. Formal exercise may not be your thing. Going to the gym, sitting on a treadmill or bicycle, things like that, that may not be your thing, but moving is what's important. So I have patients that like things like dancing. So I say, hey, go to YouTube. You can follow along with these little dance programs. They're all free. And, you're getting your body moving, you're getting your heart rate up. So, split up the activity in a way that you enjoy. And also remember, every little day, everything you do, you've got some active things you can do. So take the stairs when you can, park away from the building, walk into the building with a brisk walk, take that lunchtime break to take a quick 5-minute walk if you can. So anything that you can do to move, have bands by your office, so you can do things in between to get some resistance in there as well. So those are the sort of things I sort of push for my patients to make sure that they're moving in a way that they enjoy. Otherwise, it becomes a barrier, and they really start to think, well, I can't get it going, and they just can't get over that hurdle. So those are some of the things that I like to tell patients. We do have another question here, and I'll give this one to Dr. Kulkarni. If you've made lifestyle improvements, what is the best way to get off blood pressure medications?
It's a great question. This is always the goal that we have. If your blood pressure gets better on lifestyle medications, the goal is to get you off therapies. I would say that there is a careful dance that needs to be done to go from being on medications to being off them, and there's a risk to doing it too quickly. And so the short answer is this is a conversation and discussion best had with your personal doctor. I think that, I think physicians, as a cardiologist, I love when this question comes to me, when can I get off my medications? Because we get to have the conversation about, the success that the patient has had so far. And we usually have sort of a regimented plan. As you both know, some medications are more important than others. And so we're going to hold on to them as long as we can. And in certain other conditions, like if you have diabetes, or you already have coronary disease, you've had a heart attack, there's some medications that even if your blood pressure is normal, we really shouldn't go off of because they're beneficial at all blood pressures. And so it's a really nuanced conversation. And I think the best answer is to talk to your primary doctor about it.
I think it's also important to remind patients too that, sometimes even if you're doing your best, you have a genetic basis for high blood pressure or something that just can't be controlled, and therefore not getting off your meds should not be interpreted as failure. But instead, you should be applauded for all the work you're doing to exercise and eat healthy, and just understand that some people just have to be on medications because their body naturally has a set point for blood pressure that's concerning from a risk factor standpoint. So just reminding them that it's not their fault or it's not a failure.
Yeah, I love that you said that, Dr. Berry. I think that is so important. In heart disease especially, it often feels like this is a result of lifestyle. And so everything we're doing is because we have failed ourselves in some way. And it's a really important call out to say that sometimes it is I would say you can run away from your genetics, but you can't outrun them. And so eventually they may catch up to you, and the medication is going to be a good support for that. So yeah, thanks.
Yeah, I love that philosophy. We do have another question, and I'll direct this to Dr. Berry. It says, can you recommend a home blood pressure monitor?
Yeah, I mean, we definitely don't necessarily recommend a specific brand of sorts. I will say there are some that go on the lower part of the arm, like the wrist versus the upper part of the arm. And I will say, I think the upper arm ones are more, tend to be more accurate than the wrist ones. It's just harder to compress the arteries in a predictable way and around the forearm. So the only comment I would have was get one that sort of fits around the upper arm. And then you could talk to, your primary care doctor about the cuffs that they recommend and use, but I wouldn't say a specific brand is necessarily better than another. So I'm sorry, I don't have the best answer for that.
All right, thank you. So moving on, so Dr. Kulkarni, I'll ask you this question. What about family history? Let's talk a little bit about that. So let's say I have a family history of cardiac disease. Is there anything I can do to protect myself?
I mean, there's lots that you can do to protect yourself. So let's first talk about what family history is. So typically we say if you have a first-degree relative that's had their first cardiac event before the age of 50 as a man and 60 as a woman, in other words, if your mom was before 60 or your dad was before 50, that's considered a positive family history. And of course, that's sort of the classic family history of heart disease. I think you can have a family predilection towards heart disease as well, which is disease that comes later. If you have that knowledge, if you know that it's in your family, the main thing you can do is to know your numbers, to follow your diet and follow your exercise. So the stuff we've been talking about already. It's more and more important. It's more important if you have a family history to pay attention to those numbers earlier, because you want to see when the modifiable risk factors come out. So if your cholesterol level is higher because you have a history of familial hypercholesterolemia and it's higher in your 20s, then that may be an indication you should start a medication for that in your 20s. And so the earlier you know the numbers, the more quickly we can intervene. But otherwise, it's sort of lifestyle medications measurement, and measuring the numbers and treating with medications is appropriate.
Thank you. And we've heard a lot recently about calcium scores. Patients come in and ask me about this all the time. Can you tell me what exactly that is, and is that useful for us in terms of predicting risk for the future? And I'll ask,
Dr. Berry, I think you're up.
I was going to ask that. Dr. Berry, can you take that question?
Yes, absolutely. So calcium score is a kind of a great, I think, newer tool that we have within our armamentarium now. And I would say it's not the perfect tool still for diagnosing coronary disease. You know, we essentially are still sort of using a bunch of different modalities to kind of have the best guess of kind of a approximate of someone's risk for cardiac events. But essentially how I think of calcium is it's the end product of cholesterol deposition. So it means cholesterol has been in place for probably at least a few years, if not almost 10 years, because over time cholesterol will essentially differentiate. These cells will differentiate into kind of calcific cells or calcium cells and deposit that. And that's what you can see on a scan. So what that means to me is that somebody has had calcium and cholesterol depositions for a long time. And how I use calcium score to help me is in a younger person who tends to have risk factors or a family history of heart disease, but we don't know yet what their kind of number should be or what their goal number should be. And so we're treating them as we would the average person, but then knowing that they have this sort of elevated risk profile from a genetic basis, potentially, we can use a calcium scan to kind of confirm our concern or confirm or refute it, that they have cholesterol deposition and calcium. If they do have calcium that's visible, then I treat them with the most aggressive therapy and get their LDL below the number 70 is typically what we think about. So it helps me what we call like risk stratify somebody who has risk factors that might be above and beyond the average risk factor. It does not help me kind of typically determine if somebody needs invasive therapy or anything like that. So it's really more of a risk stratification and thinking about kind of knowing the numbers they should have based on that calcium score.
Thank you very much.
Yeah, if I could just add something to that about calcium scores. I think that Dr. Berry's distinction is super important between a marker of disease and a marker of risk. I think we often hear from our patients and family members and from the community about a positive calcium score, meaning that they have coronary artery disease. And I think that the way to think about it is it's sort of a finer tool, like LDL is a tool to help us predict somebody's risk of having a heart attack. Calcium scores can be a tool like that, but it's really a marker of risk and not a marker of disease.
Thank you. And Dr. Kulkarni, I'll ask you this question as well. When it comes to HDL, is there a maximum recommendation, or is it simply just the higher the better?
It's the higher the better, I think. So the HDL, why we started looking at HDL is because we started noticing two things. One, that in patients whose HDL was under 40, they seem to have a higher risk of having a heart attack in the future. So it predicted risk of heart attack, a low HDL. And those who had a higher HDL seemed to be protected. So it seems to tell us a sort of a barometer of risk in a crude way. And so that's why we use it. So if it's 100, I've seen patients who have an HDL of 100, that's probably wonderful. With that said, though, there have been multiple therapies that have been looked at that increase the HDL, and none of them have turned out to be useful in reducing the risk. So while we think it's a good marker of risk, it's not probably the thing that's causing the problem or protecting, because increasing the HDL using a good medicine like niacin to increase the HDL doesn't seem to change risk profile.
All right, thank you very much. And Dr. Berry, I guess, could you just tell us in general, like, what sort of things do you hear from patients in terms of what they worry about in terms of their cardiac health? And, how do you address those questions when you get them?
Yeah, I mean, I think there are a lot of things coming from patients. I think thankfully we're kind of post-pandemic now, so patients are not as afraid to at least seek care and come in and aren't minimizing all their symptoms. I think I get a lot of questions. I mean, first of all, coronary artery disease and heart disease is scary to everybody because everybody knows somebody who had heart disease and passed away from it. I mean, it's one of the kind of, more concerning things to have either be at risk for or have a history of. So everybody kind of thinks about it, I think, on some level. I think family history is a big one. I think the good news is that our younger patients are getting more informed. I think our health system does a good job of informing them of kind of risks and importance of screening. And so I think they're kind of embracing, the idea that maybe we can prevent disease rather than kind of react to it, which is great. I think that's where we should be moving the needle. So I hear a lot about family history and concerns about that. And I think all of the things that we've talked about, having a healthy lifestyle, dietary modifications, risk factor, kind of risk stratification is needed to kind of understand where our treatment goals should be for our numbers. I think all play into that as part of the answer. And I would say also, I think a lot of my patients just don't ultimately want to be on medication. And while this is inevitable for some of them, I think that really trying to emphasize that we can do so much with diet and exercise. I mean, if there's one thing if there's one of the four things that we've talked about that I could control in all of my patients, it would by far be like BMI or obesity, because that drives so much else. Obesity drives inflammation, it drives the risk of heart failure, and obviously elevates or maybe worsens all of these other numbers we talked about. So I think understanding and realizing, having that conversation with the patients that I'm not going to put you on medication right away, making sure that, they do all the right things for them for themselves in terms of diet and lifestyle, I think is what I try to focus on. I think a lot of patients just don't want to be on medication, and it's a bit of a journey with them to get them to accept that some of them might need to be on medications, but I assure them that, like, I'm there with them on that journey. We're going to do it together, and we're going to kind of work together to kind of get them to where we want them to be.
Thank you. Dr. Kulkarni, I think she explained a lot of it, but anything else that you consider alarming symptoms that patients should tell their doctors?
Yeah, so I think, Dr. Berry did a great job, but I think I see a lot of the same things she described. Symptoms that are alarming. I think that if you have a new symptom with exertion, so consistently you walk to the bus stop or down the driveway, and at the end of the driveway you're getting chest pain or shortness of breath or nausea that stops when you rest, that sort of consistent exercise-related symptoms you should always tell your doctor about. Because the way I like to describe it is the heart's the engine for the body. And so if when the engine revs up, it's demonstrating a problem, that probably means something is going on with the heart. So new symptoms with exertion or a new change in your exertional tolerance. In other words, if you used to be able to go up the flight of stairs without stopping, and now you go halfway up and then need to stop because you're having chest pain, shortness of breath, or just can't go any further. I think that those are sort of two things that you should usually talk to your physician about. You also, if you have new symptoms at rest, that also limit your ability to exert yourself, that may be a sign that something serious is going on. So those are three things that I would say are alarming symptoms.
Excellent. Thank you so much. And Dr. Berry, a question for you. So we do talk a lot about men and heart disease. Could you tell us more about heart disease in women, just in general? And also, are there any gender differences that we see in terms of presentation?
Yeah, I mean, I think maybe I'll start with that last question first. I do think that women can have symptoms that are typical, such as the chest pain that may radiate to the jaw, or chest pressure, a lot of people say, or tightness. But I think they historically certainly have definitely presented with typically more atypical or different symptoms. So these can be, exertional fatigue or even shortness of breath, nausea, sometimes sometimes stuff that can kind of go a little bit under the radar and certainly not seem to obviously be connected to the heart up front. So I think one of the things I would say, I mean, to all patients, but especially to female patients whose symptoms might be a little less clear, is just sort of listening to your body. And like Dr. Kulkarni said, anything exertional that's new. So anything that when you're walking briskly or climbing a flight of stairs, that might be a new symptom, kind of paying attention to it and bringing it up with your primary care doctor, I think is really important, because I think the studies definitely show that coronary disease is diagnosed later in women. They tend to be undertreated in terms of statins and blood pressure medications. So there's definitely gender differences in our approaches to, and I think that actually is on us too as a practitioners to kind of try to close that gap a little bit. But I do think there are definitely differences. Women are obviously at lower risk for coronary disease earlier in their lives because of the protective effects of their hormones. But there's a real catch up when women hit menopause. I think it's really important to understand that they are just as much risk for coronary disease once they're menopausal as their male counterparts. So I think really kind of understanding that there's a lot of literature too on differences in the distribution of disease. Women tend to have sort of smaller arteries affected rather than men having the larger arteries, like the trunks, the big branches of the tree as opposed to little branches. If you think about the tree or the arterial system of the heart as a tree. So there are a lot of differences in just in the actual physiology and biology that might explain some of these different symptoms. But it's important to understand that women have generally have an under-recognized level of coronary disease, and we need to be better about paying attention to them and treating it all seriously.
Thank you very much. We do have a question from the chat. Dr. Kulkarni, what other specific non-invasive tests can be done to assess hardening of the arteries?
Oh, I like this question. So because it gives me a chance to talk about what hardening of the arteries are. So I think in cardiology, I think sometimes we use language interchangeably. So it's important to be precise about what things are, what things aren't. So classically, hardening of the arteries is, as Dr. Berry described in her talk about calcium scores. Classically, hardening the arteries is when you get these cholesterol deposits inside of the lining of the heart arteries or any arteries, and eventually that turns to calcium, and that calcium makes the arteries hard themselves. What's interesting is that by itself doesn't tell us anything about what's going on inside the vessel. And though it does tell us about the risk of developing a heart attack in the future, it doesn't tell us that vessel will rupture in the future. Because there's this interesting old study that showed that a 10% blockage and a 90% blockage has the same risk of causing heart attack. And then the reason for that is that the process of a heart attack is this process where, if you think about the plaque as being a scab, the top of the scab pops off and the stuff inside creates a clot. And so that's why you get this sort of heart attack phenomenon with different levels of blockages. So I say that all to say that there are lots of tests that can assess whether an artery is hard or not, whether it has extra calcium in its vessel or not. But the question is, what do we do with that information? And in terms of the coronary arteries, the best way to ask the question is with calcium scoring, I think, and actually even just risk factor assessment. If you know your numbers, if you have your BMI, blood pressure, cholesterol, and blood sugar, you're probably getting close to understanding the risk of heart arteries.
Thank you very much. All right, so we're getting close to wrapping up here. We really do appreciate your expert time, Drs. Berry and Dr. Kulkarni. If you could, any closing thoughts before we sign off for our members?
So I got two. So one is, well, thanks first of all for having us on. I think this was a really nice discussion. So one, I think, is that if, as Dr. Berry said, if everyone can get just one version of exercise, if they can add it to their day as a result of this conversation, then I feel we will have won. And then the second thing is, one of the big things the American Heart Association is doing for their 100-year anniversary is trying to get a nation of lifesavers. So trying to get everyone in the country to have at least one person in their house who knows CPR. It takes 90 seconds to learn CPR. And so I would advise everyone who's listening to try to find a way to learn CPR in 2024. It can save a life.
Can't beat that. Absolutely. I totally agree.
Thank you very much. So I want to thank you both once again, our incredible cardiologists here at Kaiser Permanente, for joining us today and sharing ways to take charge of your heart health. We wish everyone a happy Heart Month, and from all of us here at Kaiser Permanente, be well.